Ray, it looks like Dr. Hazem is in, but not as a presenter. Ray, did you hear me?
I did. I can't find where he's in though.
Okay, in the chat, you can see. Ray, did you hear me?
I did. I can't find where he's in though.
Okay, in the chat, you can see. Ray, did you hear me?
Hello, Dr. Hazim. How are you doing? Can you put your presentation on full panel, please? It's the icon down the bottom, 3 over from where you have the cursor now. Hello, Dr. De La Torre. How are you?
Hi, Ray. Good morning.
Good morning.
Here, surviving to a virus. I don't know if COVID or not.
Oh, no, I'm sorry. I hope you feel better soon.
Yeah. Thank you for asking.
Did you test, Luis? Luis, did you test?
No,
Uh, Dr. Hazen, we can see your presentation, but we can see the slides on the side, so it's not in the full presentation mode. And we haven't heard your voice yet. I will start the meeting shortly, and then we can test. Good morning, everyone, and welcome to our International Colorectal Web Meeting. So far, we have pediatric surgeons joining us from Uganda, Iraq, Uruguay, Libya, Italy, Egypt, Mexico, Sri Lanka, Philippines, Turkey, Nigeria, Bolivia, Chile, and Slovakia, and India. So if I miss your country, please type in the chat and I will acknowledge at the end. The first presentation will be given by Dr. Hassan Mahmoud from Egypt. So Dr. Hassan, if you can please unmute your microphone and share your slides, we would appreciate. And I ask everyone else to mute your microphone while Dr. Hassan is giving his presentation. Okay. We see your slides, but we don't hear you. Dr. Hazem, what I'm gonna do is I'm gonna ask you to stop sharing. Have you worked with Ray in the background to see if we can figure out what's going on? But we're gonna move to the second presentation then, that it's from Dr. Samara Martam from Mexico, Hospital Infantil. Welcome. You are muted.
Yeah, thank you. Sorry. Hi, everyone. We are very pleased to be here in the Colorectal web meeting. I am Itamara Martin, and we are going to talk about a very strange case. On the hereditary context, we had a girl with a sister who has a Mowat-Wilson syndrome confirmed. She has a facial dysmorphism, a cardiac atrial defect, and a moderate intellectual disability. Also, she is diagnosed with Hirschsprung disease in a rectosigmoid variant. In 2018, she underwent a transanal pull-through Svensson procedure, and she's been a little clumsy evolution with 5 events of enterocolitis, the last one on October 6th. But she has been through 3 injection toxylin botulinum, and the current management of the sister is flagyl and rectal irrigations every 8 hours. So knowing all the context of our patient, she's a girl, 5 years old, with a passage of meconium in the first 24 hours. She also has Mowat-Wilson syndrome with atrial septal defect and intellectual disability. She has been chronic constipation since childhood with 2 events of fecal impactation. The last one was in 2020. And the current management with this girl is SINA. The enemas are needed twice a week. Otherwise, this patient is doing well. She has no enterocolitis, no abdominal distensions, no fever, no other cases related. So we decide to perform a contrast enema when we can see a dilated rectum and sigmoid, but there's no visible transition zone. So knowing this context, we have several risk factors for Hirschsprung disease. The number 1 is the diagnosis of Mowat-Wilson syndrome. Number 2 is a sister with Hirschsprung disease and Mowat-Wilson syndrome associated. And number 3, chronic constipation. So we found that in this article, the Mowat-Wilson syndrome is associated with Hirschsprung disease in about 50% of the cases, and 5% of patients with Hirschsprung disease present Mowat-Wilson syndrome. So here's the question. What will you do with this patient? Option A, take a rectal biopsy. Option B, continue conservative management. Option C, no treatment and stay observation. Option D, I don't know. Well, we decide, yeah, take a rectal biopsy. We perform the rectal biopsy knowing that we have 50% of possibility with Hirschsprung disease. So we perform a rectal biopsy 4 centimeters above the dental line, and guess what? She has Hirschsprung disease. So now we have a big dilemma. We have a patient with a Mowat-Wilson syndrome with Hirschsprung associated, but she's doing great with SINA and enemas. The rectal biopsy was taken due to family history and based to the association of Mowat-Wilson disease with Hirschsprung disease. And the sister, who also has Mowat-Wilson and Hirschsprung disease, has presented several events of enterocolitis and hospitalization after the pull-through. So, on the research, the outcome of Hirschsprung disease on Mowat-Wilson syndrome is unpredictable because they have a lot of issues regarding the motility disorders. The Hirschsprung disease associated with Mowat-Wilson syndrome is a severe condition, even in the case of short segment Hirschsprung disease. The patients can present motility disorders and require a prolonged total parental nutrition. In this case of 110 patients with Hirschsprung disease, 5 had Mowat-Wilson syndrome. After the pull-through, 2 patients have a stomach diversion for severity motility disorders. And another study, the 23 patients with Mowat-Wilson syndromes, 10 have Hirschsprung disease. It's like a 43%. But in these cases, the 70% of these patients require a second surgery due to complications. 2 patients of those require a redo pull-through. And the last follow-up, the 30% of the patients still had a stomach diversion with enterocolitis persistent. 3 patients report episodes of abdominal bloating and 1 recurrent treated constipation. So we have 2 questions here. Number 1, what would you do? Will you do a pull-through on this patient? And number 2, will you take a rectal biopsy on every patient with Mowat-Wilson syndrome? So thank you.
Thank you very much for this fascinating presentation. I think you are on your way to the Nobel Prize. You have 2 sisters with Mowat-Wilson syndrome, 2 sisters with Hirschsprung disease, one that has enterocolitis and one that doesn't. So number 1, for the sister that has been operated and has enterocolitis, it would be very important to have a follow-up contrast study examination to prove that she doesn't have anatomic problems that can justify why she's having enterocolitis. And if there are no anatomic problems, I think these 2 specimens should be really looked into details by a very dedicated pathologist with experience in Hirschsprung disease to understand what's the difference in the patient that has enterocolitis and the patient that doesn't. Because now we're talking about, when we think about enterocolitis, we always thought about environmental factors, immunological factors, but we're talking about sisters in which probably their environment is the same, their diet are the same. One has no enterocolitis and no symptoms for the Hirschsprung disease. The other one has enterocolitis. So I think you have a fascinating case in your hand. Now, regarding the patient with Mowat-Wilson syndrome, the case that you presented, it all depends how is the family, how does the family feels about this diagnosis and the need for the operation. I'm going to tell my version as a mom, and then I can tell my version as a doctor. So my version as a mom, I have 2 daughters. One was operated, has terrible symptoms. I have another one that was not operated and it's well managed with Senna and enemas. I would not operate on that child. That's my version as a mom. Now, my version as a doctor, I can technically not operate, provide the parents are very trustful. They live near the hospital, and in the event that she presents with symptoms, she can come to the hospital. They know how to do rectal irrigations. They know what are the symptoms, and they follow the recommendations. They never miss a clinical appointment. Then yes, this is a patient that, provided the family understand really well the risks, I would be okay not operating. I think this is fascinating. I can't wait to hear Dr. Peña and Dr. De La Torre and everyone's in the audience opinion. No?
No.
He doesn't want to. Luis, do you want to comment? Dr. De La Torre?
Yeah, just to say that the patient with Mowat-Wilson syndrome, they are completely different from non-syndromic Hirschsprung. So what you already said, I totally agree. Congratulations, Alfredo and team.
Thank you very much. Yeah, for the first, for the sister, we already did all the study to rule out a structure at the level of the anastomosis. We did a contrast enema. We review the biopsies with pathology, and the pull-through is in a normal zone. So that's why we took the patient to the OR and we do the Botox injection. But now, so we are continue with the irrigations. That's all. And for this patient, yeah, is what we also think maybe we are going to continue with conservative management. And if the patient gets worse, maybe we will talk to the mom if maybe we can do the pull-through. But for now, we are going to continue with the conservative management.
Wonderful. So, Ray, I don't know if Dr. Hassan was able to work with his microphone, or if we should move to case number 3.
Well, let's test his microphone now. Dr. Hazem, can you talk and say something, please? Dr. Almoud?
Yeah, it doesn't look
Doesn't sound
like.
like it.
Okay, so I'm gonna move to Dr. Vache Melkonian, who is our pediatric colorectal fellow here at Children's Hospital Colorado. And Alfredo, if you can stop sharing, he can share. Thank you.
Okay, good morning. So today we're going to talk about a failed Hirschsprung's pull-through on a patient that we recently operated on. So for this patient's outside hospital records, the baby was born full term, 39 weeks with good prenatal care. Day of life 2 was noted to have abdominal pain, distension, emesis, and free air was noted on the KUB. So the patient was taken to the OR on October 15th of 2013 for an XLAP, and they saw a cecal perforation, which they repaired, and they did a leveling biopsy procedure to see where the ganglion cells were not, to see where they could pull out a safe transverse loop colostomy. So in this patient, after the initial surgery, what would be your subsequent operative approach? So it would be a Swenson pull-through, a Suave, Duhamel, transanal, or permanent colostomy. Okay, so as it is in the literature and everybody's opinion, it's pretty much all over the place because everybody does a different technique. So in this case, the patient at 5 months of age underwent a Duhamel pull-through with a leveling procedure. Of note, in reviewing the operative report, the ganglion cells were just beyond the transverse colostomy, but when they took that down, it sounds like it devascularized the transverse colon. So the Duhamel pouch was the right colon to the rectal pouch. Throughout the next 5 years, he had multiple visits to the emergency room, urgent care, GI, complaining of diarrhea, bowel obstructions, explosive fecal bowel movements. Underwent a colonoscopy that found no abnormalities, but found a colon length of 30 to 40 centimeters. The patient tried laxatives, Miralax, suppositories, but was eventually resistant to all medications because nothing was working and the child no longer wanted to use any of these medications. It was also described that he preferred to stand during bowel movements because of the pain and straining, and he was wearing diapers at all times. So he presented to the emergency room in February of 2019 with abdominal pain, constipation, and emesis, and underwent enema and a go lightly clean out from an NG tube that was placed. But this was complicated by sepsis and an intestinal perforation secondary to the clean out. So he underwent an XLAP, an ileal segment resection where the perforation was found, a creation of the endoileostomy, and a Hartmann's pouch. And this is a CT scan from that time immediately prior to getting his clean out. You can see on the right side is very, very dilated colon coming into this Duhamel pouch. And this is just a still frame of that same CT scan on the coronal view. This baby then came to see us on June 30th of 2020, where we did a XLAP, lysis of adhesion, ileostomy takedown, and a hand-sewn ileocolonic anastomosis. And for the next 3 years, continued to have constipation, fecal incontinence, enterocolitis, anemia, secondary to intestinal bleeding. And GI actually started mesalamine because it was elevated fecal calprotectin. So at this time, they started to change their diagnosis to possible IBD or inflammatory bowel disease. And erythema was noted on their small intestine video capsule endoscopy, but repeat colonoscopy did not show any abnormalities. So on the 2nd of October, we started with irrigations to prep the patient for an additional surgery, and 14 liters of irrigation with significant stool burden was taken out. And we saw an extremely large megarectum, about 20 centimeters in length, with a rigid proctoscope. Did the same again later that month with 6 liters of irrigation because of repeat significant stool burden. And this is a scan of his, or x-ray of his bowel. You can see this very large dilated colon that's coming down into his pelvis. And I believe this is after we actually irrigated him out, so all of the stool that we could get out was evacuated at this time. So what is your operative approach? So for this patient, do you do an XLAP and an ostomy without resection of duhamel anastomosis, or an XLAP with an ostomy with resection of duhamel? The same procedure with an ileorectal anastomosis, or do the anastomosis and divert with an ileostomy, or do a staged procedure and pull out an ostomy and then resect the duhamel pouch and come back later on for an interval ileorectal anastomosis. Okay, so split mostly between doing the diverting ileostomy and doing the ileorectal anastomosis up front versus doing it afterwards. So we chose to do it in a staged procedure. We prepped the patient with Go Lightly. We did an XLAP with lysis of adhesions. It was a severely dilated proximal bowel to the duhamel anastomosis, which I'll show you in a picture. The bowel was divided immediately to this transition point. And then given his anemia, his malnutrition, we decided to do this in a staged procedure. So we dissected the massively dilated duhamel pouch down to healthy rectum. We tagged it with proline sutures so we could find it again later on. We reinforced the staple line, and we matured an end ileostomy. So in this picture, you can see at the very bottom of the picture in the center is the anastomosis into the duhamel pouch. We have made a bigger mesenteric window there just to be able to see that transition point. And then the massively dilated duhamel pouch is below this. And then this is where we're dividing across this massively dilated duhamel pouch and showing basically how many staple lines with 100 centimeter staple load it took to get across this large dilated rectum. The pathology that came back was as expected. There were ganglionic segments in the duhamel pouch, which is part of the procedure of the duhamel. But in the small intestines, we did see acute inflammation and fibrosis, which likely was secondary to this chronic inflammation and stasis of his colon. Patient was placed on TPN post-op, given the malnutrition, so we started TPN right away rather than waiting. He had ostomy function within 2 days after surgery, was started on a clear liquid diet. We stopped his TPN on post-op day 5, and he was discharged home on post-op day 6. And he's supposed to follow up with us next Monday. So our next steps was to give the patient time to improve this malnutrition and possibly in 6 months return to the OR to restore continuity, do a ileorectal anastomosis, and then decide at that time if we want to do a protective loop ileostomy as well. Thank you.
Thank you, Vachi. I didn't understand, what was the first surgery that was done in our hospital?
The first surgery that was done was, let's go back. This was to take down the ileostomy that he had after he had his perforation, because when he got prepped, the procedure prior to this in 2019, he perfed his ileum. So they did a damage control laparotomy and basically pulled out an ileostomy in a Hartman's pouch. And then he was sent to us. And on this surgery, what we did was we took down his ileostomy and did an ileocolic anastomosis.
Okay, understood.
Bache, Bache, somebody is asking why did you decide to do the Duhamel? So I think they don't understand.
Okay. Yeah. So the Duhamel pouch was actually done, I believe it was Arizona. It was done at a different state when the baby was born. So that was a decision from the hospital team that first took care of this baby.
Thank you, Bache.
There's another question. Was the Duhamel anastomosis at a higher position on the rectum or as low as possible?
So it's a good question. When reviewing the operative note, they said that they made it all the way down to the floor and they were able to palpate their finger from beneath. And so they said they made it as low as possible. I think what happened was, if that's truly what they did in the operative note, what could have happened was as it became dilated, it basically lifted this up and the whole rectum got dilated. So it looks like it's higher than where it was initially. But the initial operative note says that they placed it at the very low posterior position as normally described in the Duhamel procedure.
Dr. De La Torre, do you want to comment?
Yeah, I think I don't want to comment about the Duhamel because we have our theory about what happened in this Duhamel, which is very important. But the most important is we have patients with Duhamel and J pouch or other pouch in total colonic or whatever. And these patients are coming to our center because they have chronic obstructive problems. My big concern is that all these patients already are seen by our colleagues GI here or in another states, and they are getting treatment for a patient with an IBD, inflammatory bowel disease. So all these patients have steroids and all the medications for IBD. Once we start to do the irrigations to resolve the, at least medically, this obstruction, all these patients start to be much, much better. And after we studied this patient, none of these patients have IBD. Recently, there is a paper that was published in the Journal of Pediatric Surgery about the association of IBD and Hirschsprung. Be careful about this paper, because now everybody wants to explain these obstructive symptoms, not just in the transition zone, because now they blame that these patients have IBD. Of course, IBD could be an association with Hirschsprung, but is not always. It's very rare. In Mexico and Latin American, IBD is not very common like in the United States. So be aware of this situation, because we are receiving more patients with obstructive symptoms due to Duhamel or J pouch or whatever, and they are getting tons of medication for IBD. And at the end, they don't have IBD. I think this is most important, that the discussion of the Duhamel in this particular case. Thank you, Bache.
Thank you, Vachi. Dr. Hassan, do you want to try your microphone now? We're very hopeful it will work.
Can you hear me like?
Yes, we
You
can.
can.
Perfect.
Yes, thank you. Perfect.
So
Excellent.
now let's go to the first case. That will be the third case.
Do you want to share your screen now, please? Are you able to share your screen?
Maybe Ray, can you share the screen, Ray, and then he just talks since now
Yes.
he has a voice?
Looks like we have.
Okay, Dr. Hassan, please go ahead.
Can you hear me like this?
Yes, we can perfectly.
Yes.
Thank you.
So, my name is Dr. Hazem Hassan, and I am a pediatric surgery specialist from Egypt, and I am going to present an interesting case including caudal duplication syndrome with an anorectal malformation and myelomeningocele. The case was a full-term male neonate that was born at the 37 weeks of gestation to a 35-year-old female with lack of antenatal care, and the parents did have two previous children with no reported congenital anomaly. The neonate was complaining of an anorectal malformation with bilateral anal dimples, duplicated external genitalia, right and left one, with two testes only. The right one is located in the right hemiscrotum, and the left one is located in the left hemiscrotum. On gentle pressure on the abdomen and the pelvis, meconium expressed from the left urethra, while the right one, nothing came out. Also, the neonate is complaining of incomplete midline accessory limb. And he was also complaining of large ruptured myelomeningocele with complete loss of the sensory and motor power over the lower half of his body. The investigations we did a plain X-ray for the chest and the abdomen, and the following was reported. He has duplicated sacrum and single right and left iliac bones with 4 inferior pubic rami, and the 2 centrally located ones are fused together. The echocardiography, there is a moderate-sized non-hemodynamically significant patent ductus arteriosus. There is a patent foramen ovale. The ultrasound showed mild right hydronephrosis with the renal pelvis AB diameter measuring 7 millimeter. And the most significant thing about this investigation, that the bladder capacity was 75 cubic centimeter. And even after repetition of this investigation, after 1 hour, there is no spontaneous evacuation of the bladder, which means that the neonate is complaining of neurogenic bladder. And we did voiding cystourethrogram. At first, we tried to calibrate the right-sided urethra with a 6 French Nelton catheter, but we failed. So we did ascending uretherogram, in which the contrast didn't pass through the urethra and didn't reach the urinary bladder. And then we did another trial from the left-sided urethra, in which the dye reached the urinary bladder, but not fully distended. The bladder didn't become fully distended, as the dye is leaking from the right urethra. And there is and the VCG showed that the presence of recto-urinary fistula, but the exact location of the fistula cannot be determined from this investigation. About the operation did to the patient, at first we did closure of the myelomeningocele, and we performed diversion in the form of left simple loop transverse colostomy. After that, the patient is good, but he developed obstructive hydrocephalus with marked increasing of the head circumference, confirmed on CT brain, and upon which right ventricular peritoneal shunt was performed. And then while the neonate was following with us in the clinic, he developed a bilateral inguinal hernia, upon which elective bilateral herniatomy was done. Then after the patient was 1.5 years, we repeated the VCUG, and the VCUG showed that no contrast passed toward the right-sided urethra and normal appearance of the left anterior and the posterior urethra with no strictured segment filling defect or divertically, but there is significant post-voiding urinary residual and no evidence of vesico-ureteric reflux. And then we did MRI associated with magnetic resonance urography that showed that there is duplicated sacrum in which the right-sided is formed of 5 segments. The coccyx is tilted medially and open sacral canal is seen. Left-sided one formed of 5 also segment fused last 3 segment, and the coccyx is tilted medially, open sacral canal is seen. There is single urinary bladder is epicentered in the left side pelvis. And there is only single kidneys with single ureter. Also, there is no duplication of the colon or the small intestine. There is no duplication of the vasculature. There is single abdominal aorta, common iliac. There is bilateral single ureter. Then there is complete duplex penis. And regarding the pelvic floor muscle, on the right side, there is no near total atrophy of the pelvic floor muscle. And on the left side, there is near completely development of the pelvic floor muscle on the left-sided pelvis. Thank you.
Thank you very much. And I think the audience can type in the chat. Those very complex malformations, sometimes they are fascinating for us surgeons because it's almost like a puzzle. We have to find and understand the anatomy completely before we can plan for surgical reconstruction. In your patient, it seems like the internal anatomy is not as complicated as the external anatomy, meaning that he seems to have one single bladder and one single colon, normal kidneys, normal ureter. What is sad in your case is that this large myelomeningocele and apparently no function in the lower extremities. I think this has to be taken into consideration when we are thinking about the reconstruction. So, number one, I saw that you did a loop transverse colostomy in patients that we know there is a communication with the urinary tract. We prefer separated stomach to assure there is no stool contamination of the urinary tract. It would be important to do a distal colostogram so you can see exactly where the rectum opens in the urinary tract so you can plan the reconstruction. This patient, it seems like the left side is the good one. That's the patent urethra that goes to the bladder. So most likely this is going to be the penis that will stay, the urethra that will stay. This has to be confirmed before any decision is made. This accessory limb will have to be removed. It's important to see if there is bone on it or not. And plastic surgery will need to be involved for the reconstruction. So upon removal of the single limb, there will be bringing together this scrotum, since one testicle is in one side and the other in the other side. But again, we're talking about a patient that we don't expect bowel control with this significant malformation. So, and the fact that this patient will not be ambulatory makes the decision about a pull-through one that has to be taken into consideration with the parents to see what's the best quality of life for this patient in this scenario. So I think those are my comments. Do you want to comment?
Just a suggestion that when you present complex, very complex malformation like this one, it will help everybody, the audience, to see a diagram of your final concept of the anatomy. It is very easy for the audience to figure out exactly how is the internal anatomy in a complex case like this. So you see, look at all these studies, and at the end, make a diagram showing what you think is the anatomy. And that way, people will be able to discuss, to have more elements to discuss your case. Is a very complex, and the discussion about this patient is going to be a long one, taking into consideration urologic issues, colorectal motility, motion of the extremities, neurosurgery, and social, economical, and even religious concerns about this patient. So it's very difficult in such a short time to involve all those aspects in this complex case. But congratulations for your efforts in improving this patient.
Any questions from the chat? Let me see if anybody has any questions. I don't think so. Dr. De La Torre, do you have any comment?
No, thank you.
Okay. Well, thank you very much, Dr. Hazem. I think those are fascinating and unique challenges. Please keep us updated on what happens and how you manage this patient. And I think it's very important to involve plastic surgery because they will need to help you for this reconstruction too. So the last case will be presented by Dr. Diego Martinez. He is also from Hospital Infantil de Mexico, but he is visiting us in Colorado now. So welcome, Diego.
Hi, thank you. And good morning to everyone. I want to thank Dr. Bishop, Dr. Peña, and Dr. De La Torre for having me at the International Colorectal Center in Denver. It's been an amazing experience. So we have this case, a 10-year-old female who was diagnosed with a cloaca since she was born. She had a colostomy in 2013. Then we met her in 2014 and started a complete workup. Renal ultrasound was normal, and we made the diagnosis of a cloaca, a common channel of 2 centimeters, and hemivagina. The sacral was 0.86, and she also had tether cord. We performed a PSARP with total urogenital mobilization in 15 when she was 2 years old. And then we did a colostomy closure 6 months later and started our laxative protocol with half a square of X-lax. 1 year later, in 2017, we had to increase the amount of laxative due to constipation to 2 squares and then 3 squares with occasional enemas with normal saline and glycerin. In 2018, when she was 5, we the final diagnosis of fecal incontinence and neurogenic bladder. She began then with clean intermittent catheterization and enema with 350 milliliters of normal saline and 15 milliliters of glycerin. She continued our bowel management program. We can X-ray when she began in 2018, and then in 2019, increased to 20 milliliters of glycerin. And in 2020, she reported that her recipe was just with no accident. So she was just doing fine. Nevertheless, in 2021, she described having accidents before the next enema with daily colic pain and pain after the enema infusion. So here we want to ask, with these symptoms, what will be your next step? Okay, so many people will increase the saline and also the glycerin, and 70% will stop the enema. Well, in 2022, she began reporting increasing time to evacuate the enema fluid. So we decided to increase the amount of glycerin to 30 milliliters. So it was now 350 of normal saline and 30 milliliters of glycerin. However, she kept having occasional abdominal distension and pain. And in January 2023, she went through a spinal cord surgery. So now, with colic pain, having accidents before the next enema, increased time to evacuate the enema, what will be your next stage? Your next step? Yeah, so many people as us on August, we did a contrast enema, shows a spastic descending colon. No stenosis was seen, so we decided to decrease the enema to 300 milliliters and no glycerin. However, in the next 3 months, she keeps coming to the clinic because the enema was not working and she was having occasional colic pain. Her enemas varied from 10 to 15 milliliters of glycerin, and she had a hard time passing stool. We have to say that the abdomen is always soft, it's just colic pain, mild distension, and hard time to pass stool even with the enema. So we believe this may be a truly case of enema-induced spastic left colon syndrome. So we want to ask the audience, have you had similar cases? What has been your approach, or are there any other comments? Thank you.
Well, I was personally kind of shocked when we found several of our patients that had been on bowel management that had the very narrow spastic left colon. And we didn't know what to do, and we still don't know exactly what to do. And we decided to, there was the secondary effect of the enemas. And one alternative was to do a colostomy. Somebody suggested that we could do fecal transplant because somebody suggested that the changes in the colon were consecutive to the absence of the normal flora. We are removing with an enema, maintaining clean a colon that normally is full of stool and has bacteria. So that, and at that point I retired, so I don't know. I still don't know what to do with those cases. An alternative is to stop the enemas for a period of time and see if the colon can be rehabilitated. And another would be a colostomy, of course. Now, it certainly, the contrast study of your patient shows a very narrow colon. And then if you look carefully, Dr. Bishop was telling me here that if you look carefully in the left upper quadrant below the diaphragm, there is a dilated loop. There is like a sharp demarcation between a dilated piece of bowel and the very narrow. So before jumping into the diagnosis of spastic left colon consecutive to enemas, be sure that the patient doesn't have some kind of mechanical obstruction in the left upper quadrant. If you look at can you put the image again of the
the one you have, or the one you have the 3 X-rays, you can see.
Yeah.
You see,
Yeah, here, this is
that's why there is a persistent image of a dilated colon there. And the question is, what is there between that dilated colon and the narrow spastic colon? Is there a mechanical obstruction? You have to rule out that before other considerations.
Yeah, so when I saw this case, and I know I already mentioned to Diego, for me, it doesn't ring the bell as a spastic colon. I would be very curious to understand what's going in that area. Was that the colostomy site? And we have a stricture. You could see that in colonoscopy, for example. But also in the contrast enema, we see the difference in caliber, but we still see bowel behind very dilated. So is that small bowel For me, there is something, yeah, there. You can see that the contrast comes and go, but there is still dilated portions behind. So I am not sure what is that. I would do an upper GI. I would really, really investigate this patient. I think a biopsy is not a bad thing in this case. And we have to remember, this is a patient with a short common channel, cloaca, a good sacrum. She was not in a very high laxative dose. She was on 2 squares or 3 squares, which is not bad. It's not a large amount. So I think in this case, we are obligated to rule out a mechanical problem.
Operate and see what's there. Operate and see what's there.
You could, but it's just a difficult area. I mean, with laparoscopy, I guess you could see it. But I would do an upper GI, a colonoscopy. I would biopsy her. I would just map this entire bowel. I think there is a mechanical problem there. I don't know what it is, but I think there is something that is causing the symptoms that she reports.
Perfect.
Let me
Thank
see.
you.
I think there is a lot of comments from the audience. Let me take a look. Somebody's saying colonoscopy, laparoscopy, and biopsies. Can it be a segmental dilation of the colon? I would do an upper GI, water soluble, rule out Hirschsprung. So I think everybody believes that there is a problem. And there is one question. Would you consider an antegrade enema procedure? That's a very good question that demands a long answer. But if the patient is having problems with enemas from below, patient will have problems from enemas from above. That's normally what we see. The antegrade enema procedure is just a different route of administration. So I don't think I would jump on that. Question of cystic fibrosis. I don't know how often that happens in Mexico. And there's a question why you want to do an upper GI. The reason why I want to do an upper GI is because when I see the contrast enema, I still see dilated bowel loops behind that area of the colon in the splenic flexure. So I don't know what that is. I want to see the stomach. I want to see the duodenal. I want to see the small bowel. It's just, I think we're missing information. And then Diego will have to come back with a follow-up of what you found. Yeah, there's another comment, rule out Hirschsprung and take colonic biopsy. I think those are all the questions. Thank you very much. Very interesting case, and we look forward to see what you find. So for next month, in December, we're going to have a colorectal review course on December 14th. So it is free, it is online, but you need to register. So please register. And instead of the web meeting, we'll have a quick review about all the topics. If there is something that you are interested in listening, please send to us so we can incorporate into the agenda. And then on December 15th, that it's the Friday, we're going to do a similar meeting, but that time will not be for physicians. It will be for parents and patients. We believe that it's important to empower our patients. The more they know, the more they will follow the recommendation if they understand the rationale for it. So if you have patients, please ask them to register. And if there is items that you or your patient would like to have in the agenda for this patient family web meeting, please send to us. Again, it will all be free online, but registration is required. So thank you everybody for joining us. And again, today we had pediatric surgeons from Uganda, Iraq, Uruguay, Libya, Italy, Egypt, Mexico, Sri Lanka, Philippines, Turkey, Nigeria, Bolivia, Chile, Slovakia, Pakistan, Saudi Arabia, Russia, and India, and the United States. So thank you very much. And we hope to see you all in our quick review course in December. Thank you very much. Bye-bye.